Good evening, doctors. On behalf of GE Healthcare, I welcome you all on XP Connect webinar series. It's my privilege to welcome Dr. Ashok Khurana for today's session on congenital anomalies of kidneys and urinary tract. Dr. Ashok Khurana is well-known name in fetal medicine, and he is also a SWOG ambassador in India and South Asia. Now I would like to invite Dr. Ashok Khurana to start the session. Over to you, sir. Thank you.
Thank you. Thank you very much. And my thanks to our trade partner for tying up with us, as always, to bring you something new and interesting. In the series of webinars that we have ahead, we're going to bring you a set of nice topics which we'll announce as we go along. Tonight, we are going to discuss what is something that has a new acronym to it, congenital anomalies of the kidney and urinary tract. And it is becoming fashionable to now call it C from the congenital, A from the anomalies, K from the kidney, and U and T from the urinary tract. So it's called CACUT. And I will discuss newer approaches. There's a lot of old stuff that we will go through and which we'll still use. But the idea today is to unravel some of the newer stuff, because there are a lot of threads that seem to have got entangled between the old and the new, including things like classifications, which I will take you through. I will help you to understand that this is a normal kidney in transverse section, and so is this one. And of course, that when you look at this particular pattern, you can be absolutely sure that this is a recognizable pattern. So all this is important for a very important reason, and that is that 1/3 of all anomalies are in the urinary tract, and that's significant enough. But even more importantly, we have about half of them, 45%, which form not isolated abnormalities, but a part of aneuploidies and syndromes. And this is what truly makes the whole matter far more important. There's no doubt that abnormalities in the urinary tract are very common. They're almost in 1 in 10 of every person, 10% of the population. But that does not mean that they will have a clinical significance. Most patients with the more common forms of maldevelopment, such as a bifid ureter or a horseshoe kidney, will have no significant complications throughout their life, and most of these will be chance findings for some other clinical problem. On the other hand, we have some very serious diseases, such as the renal cystic diseases, and also the rest of the CACUT, which represent the most common forms of end-stage renal disease in children, which means that there is an identifiable abnormality at the level of the fetus, which will account for a whole lot of problems afterwards, and also be responsible for chronic renal disease and renal failure in children. And therefore we need to be careful about this. And it's not just about autosomal dominant polycystic kidney diseases, etc., but a whole lot of other conditions which I will take you through. And therefore I will discuss classifications, some old ones and some new ones, some clinical ones, norms, and what we need to measure. There's always this long list that you and me get confused about, and we need to sort that out. We'll discuss technology, because you may not need all of it for the urinary tract, but you may need a lot of it where it is required. There are some newer algorithms for daily practice, and these become important. There will be the relevance of some findings and the irrelevance of some findings. And importantly, to figure out that everybody in healthcare would be on the same page. We work as a team when we work with the fetus. We have the general obstetrician. We have the high-risk obstetrician. We have fetal medicine experts with a background in obstetrics. We have people who do imaging. We have genetics. We have pediatricians, neonatologists, pediatric surgeons, pediatric nephrologists, pediatric urologists, counselors, and we have to all work together, because that is the essence of good fetal health care and good fetal outcomes. And so we'll make sure that all of us think of exactly the same options when we go through this topic, and at the end of it we will have a consensus on how best to handle this. There is some old wine in new bottles, because it has to be looked at differently, and we will emphasize this as we go along. And I do hope you will benefit from this. It's nice to meet on an electronic forum, rather than a personal one, because we know how Corona has been so unkind to the world. Politics and the rest of bureaucracy apart, I'm so glad that we are blessed here, and I do wish all of us the best in India for overcoming this. Let's move on to the first of the scientific part of the program, which is the original classification by Peter Dubélé. He came up with this many, many years ago, and it's almost 30 years since he came up with this classification, but it's still very, very useful to use on a regular basis. He divided all conditions in the fetus as hydronephrotic and non-hydronephrotic as the two basic categories. The hydronephrotic are three types: obstructive, vesico-ureteric reflux, and the Pruneberry syndrome. And the obstructions may be at the uretero-pelvic junction, the uretero-vesical junction, which is the primary megaureter, and urethral obstructions. And the non-hydronephrotic ones include renal agenesis, infantile polycystic kidney disease, also known as autosomal recessive polycystic kidney disease, multidysplastic kidneys, which we will talk a lot of today because there are new approaches to this, duplex collection systems, and we'll discuss imaging of these, renal ectopia as part of a differential diagnosis, renal tumors as an overview, and bladder exstrophy, and go through exactly what is new here and what we need to do, and we'll throw in a lot of genetics, like I said. Now, this is what you and me use as an everyday classification to try and think on how we should best write our reports when we do imaging, and also then to move on to fill up those little areas in the form that a clinician would like to have filled up so that they can make a reasonable decision in terms of expectant management, in terms of mode of delivery, timing of delivery, place of delivery, the kind of personnel to be present at delivery, and the kind of tertiary care required, if any. After all, there would be conditions that would require no immediate tertiary care, and you don't have to deprive the patient of delivering at her primary obstetricians when all that's going to be required is a follow-up after days or weeks or months. What we never seem to be on the same mode about is working with the pathologists. And they have a different way of looking at this. In fact, there's many pathological working classifications. But the one that I find very useful is this one from 1966. And this is because it helps us to think correctly and classify disease that we're going to be looking at in terms of a reasonable perspective of what we see on imaging and what needs to be done in terms of a complete diagnosis, a prognosis, and a follow-up. So we have abnormalities in the amount of renal tissue. We have anomalies of renal position, the shape of the kidney and orientation of the kidneys. We have anomalies of differentiation, and in this we have several categories which we will discuss. In the anomalies in the amount of renal tissue, you could either have a deficient definitive renal parenchyma, which means either no kidneys, bilateral renal agenesis, or a unilateral renal agenesis, and of course a hyperplastic kidney, which may be unilateral or bilateral. You might have excess renal tissue, which is a duplication of one kidney or a supernumerary kidney altogether. In terms of the abnormalities of position, the kidneys could lie anywhere, as we know, between the renal pelvis and the renal fossa, and sometimes they go a lot higher and they might even enter the thorax as a diaphragmatic hernia. And it might be a simple ectopia, which means on the same side as the kidney was originally destined for, or crossed ectopia, which means it crosses over the midline and goes and lies next to its partner on the other side. And as long as you have that in mind, you will realize that if you don't see a kidney on one side of the abdomen, it's well worth looking for that same kidney on the opposite side of the abdomen. There could be renal fusion, which is very difficult to detect antenatally and even at surgery, and so we don't talk much about it. The anomalies of rotation are important because very often when we see a kidney that is not rotated entirely like it should have during embryology, and it still faces in a different rotation, then we tend to overdiagnose pelviectasis. Pelviectasis, like we should do, should always be in an axial section, and the axial section may not be the section that looks at us in these malrotated kidneys, and therefore you need to be careful that when you do call it a dilatation of renal pelvis in a malrotated kidney, you must have a nice section in the axial view of that kidney. In terms of the anomalies of differentiation, we have renal dysplasias, which may be total, segmental, or focal, and they may or may not be associated with congenital obstruction. You have polycystic kidney disease, which broadly speaking is the adult and the infantile type. You have medullary cystic disease, which is the sponge kidney, which is the echogenic kidney, and the uremic medullary cystic disease, which means that essentially the kidney gets destroyed at a very early stage and that all that is left is a dysplastic kidney tissue. You might have solitary or more simple renal cysts. You might have multilocular renal cysts of congenital origin. All of these are very innocuous. And you can have miscellaneous cysts around the kidney in the retroperitoneum. Very rarely the peripelvic, the parapelvic, which are the other ones of nephric origin. But importantly, you could have teratodermoids in the kidney. You could even have endometrial cysts of the kidney because of the kind of origin that we have of the genitourinary system. And of course, you have to keep all of these in mind when you're looking at focal lesions in the kidney that are solid. Now, why do we have all of this written here on a chart when we're talking about imaging? Is that we have to make sure that when the pathologist sends you back a report on an autopsy, we know how to handle it. They might want to call something a little different, but we will then request them that could you please follow this particular classification and tell us, because that's the one we understand and correlates best with imaging. And that's been a general consensus over the last few years that perhaps this is the best working classification. It's called the Kisan 1966 classification and is available as a free download on the internet. Let's move on to the next bit, which really hasn't changed, and that is the normal appearances. We do understand that in sometimes with the newer transducers, especially with the vaginal approach, we might end up picking up kidneys as early as 9.5 weeks, but that's not really the time we look for them. We do understand that by the time we've reached about 11 to 12 weeks, we'll pick up most of the kidneys, and by 16 weeks, we should be able to pick up almost all the kidneys. The important thing to realize in this whole story is that the pyramids may not be seen as late as 26 to 28 weeks in low-end equipment. And that becomes extremely important, that this kind of a differentiation, which you might pick up as early as 18 to 20 weeks on high-end equipment and the newer equipment, may not appear like this. And therefore you have to keep that in mind, that look, a kidney that does not show pyramids and not using the finest of equipment might look just like a homogeneous haze, and it will be perfectly normal, and I will not overdiagnose an abnormal kidney. We will come to measurements later, but there's a good illustration here that truly speaking, the important measurement is the anteroposterior diameter of the kidney in an axial section of the renal pelvis. And we put the plus points on the white portion of the actual renal pelvis wall, and then measure the distance between that, and you measure that and mention it in the report. The overall measurement of kidney size is done more as a matter of routine for comparison later on in case you find an abnormality. When you have a doubt on whether a kidney is a hypoplastic kidney or not, or in case you see an abnormal kidney such as an echogenic kidney, then we know that the differential diagnosis of a small echogenic kidney is quite different from the differential diagnosis of a large echogenic kidney. And remember that although it is traditional for many of us in the world of radiology to just measure the length and the width, it is wise to actually also measure the thickness of the kidney in an axial view so that you have an anteroposterior diameter as well. So the kidney should have a mention of 3 dimensions and an AP diameter of the renal pelvis. Remember that these ureters are usually not seen in the fetus unless they are dilated. And the urinary bladder needs to be always confirmed as being the urinary bladder. So if you do not switch on your color and don't see the umbilical arteries around it, you will never be 100% sure that this is the urinary bladder. It could well be a cloaca, it could be a cystic mass, and it could be a collection in the lower end of the digestive tract, in the rectum and the sigmoid. And therefore always have equipment that has color on it, so you're confirming that a fluid collection in the lower abdomen is truly the urinary bladder. Remember that when you look at the thorax and abdomen, you will always like to be sure that it always shows a urinary bladder, and therefore you will watch the filling and the emptying of a urinary bladder. you will differentiate from cystic spaces that you see around, including the stomach, the gallbladder, the oral sinus, and so on. And then go on to make sure that yes, indeed, the kidneys are kidneys. The kidneys are best seen when the spine is anterior. And this position, the 12 o'clock position of the spine with an oblique view to show both the kidneys, is the best way to demonstrate that both the kidneys are truly present. Remember that the kidneys are almost never, except in 10% of the population, at the same level. So when you do see a cross-section like this, you can be quite sure that it's actually an oblique section. But you're doing it to show both the kidneys, and then you will also use it to measure off the anteroposterior diameter of the kidneys as well as the anteroposterior diameter of the renal pelvis. The renal pelvis can be slit-like, as you see here, or it might be a little more full, and this can be quite normal. Also remember that if the fetus is well hydrated, because the mother is well hydrated, the renal pelvis might appear more full. If the urinary bladder is full, the renal pelvis might appear more full. Remember also that in the standard section for the abdominal circumference of the fetus, where you see the stomach and the portal sinus, the structure seen behind the stomach is not the kidney. That is the suprarenal. And one of the biggest mistakes we make in missing a missing kidney is to mistake the adrenal. And we will talk about this as we go along and talk about how you can tell the difference. Usually you will see the adrenal as a smaller structure, but sometimes you might see it as a bigger structure. But do remember that if you're using your abdominal circumference section to look at anything, A, you're not going to be able to, you should not be able to see the kidney, and this is not the kidney. B, that the best section apart from the 12 o'clock spine would be a 6 o'clock spine. And since our abdominal circumference is done usually with the spine either in a 3 o'clock or a 9 o'clock position, this is not the best section to look for kidneys. For the kidneys, you always need a special section. And of course, the story doesn't end in just looking at it in the axial section. You have to look at it in longitudinal section as well. Looking at it is possible even in an earlier window, and these are images that I have taken from Ravi Chavi's book because they really illustrate the point well. Now, when we look at the 12-week fetus, we do 3 sections. One for here, where we see the stomach and the portal sinus, and we see the spine at the back. The second section is at the level of the cord insertion. And again in this, depending on how you slice through, you may not see the kidneys at the back. And the third section is from the cord insertion down through the bladder, and here again you will only see the bladder. So the classical sections really do not intersect the kidneys, but if you want to look for the kidneys, you will look for them either in a oblique section where the kidneys will often appear almost isoechoic to the rest of the abdominal viscera at 12 to 14 weeks. And of course, you might not see them in about 10 to 20%. They're often at the same level, and we don't get worried about that. That's because the fetus is so tiny. And that if you're using some of the newer equipment, and if you're using harmonic imaging, you will often find that the echogenicity is almost identical, or the kidneys might actually appear more echogenic at this stage. So if you have any doubt, just switch off the harmonics and try and see what is going on, or use an old-fashioned transducer and see whether they're truly echogenic or not. Very often, the kidneys might stand out much more in a posterior coronal section of the fetus, in which you might see most of the ribs, you might see part of the spine, and then you see these 2 echogenic areas at the back, and they appear fairly bulky, and those are the kidneys in fact. But invariably, when you see these, remember you're on the right plane if you're seeing the iliac wings, and then you won't mistake these. But usually what happens is that the reniform shape stands out so well that you will know that this is a kidney, and you don't really require any clues beyond that. The tendency for many of us not to magnify is a little difficult to understand. We often give images like this where we say, oh yes, this is beautiful, I see iliac wings, I see the kidneys here, I see stomach here, and so on. But it's not wise to do things like this. We must make sure that the area of interest occupies everything, occupies most of our screen, And that way you should be able to see it much better. You might even be able to see it in minified views like you see in this particular fetus. You're seeing a lot. You're seeing the ribs, the lungs, the liver very well seen, the stomach bubbles seen, the urinary bladder seen. And if you focus from side to side, you are sort of picking up the kidney here. But that is not the way we like to look for these things. The way to look for it is always to magnify and then do it. Now, a few tips as we go along. We must, of course, identify the fetal bladder and both kidneys in all fetuses. And if either the urinary bladder is not seen or the renal pelvis appear enlarged, measurement should be documented. You don't need to measure the kidneys routinely at the time of the 11 to 14 weeks window or at the time of the anomaly scan or in growth scans. We measure them only if we think that there might be a requirement for a measurement later on, such as a dilatation, or in case there is something in the history that suggests that the clinician would like to know that I have measured these, that I'm definite that I'm seeing something for sure because I'm measuring it only when I'm seeing for sure, and measurements always ensure that you've seen an organ very well. Then in that case, of course, you'll measure it and mention the measurements, but typically speaking, you don't need to give measurements. And of course, if you don't see the bladder, then you start looking for kidneys all over again because you might have mistaken an adrenal. The adrenal actually moves away from its relatively axial position to a more vertical position when the kidneys are absent, and it comes to occupy the entire renal fossa on both sides. You might see it better on one side, you may not see it as well on the other side, but in general, the more you look for it, the more you will be able to see it. And it's always a good idea to always try and look for both the adrenals and try and identify them so that when you get stuck with a lying down adrenal, you know how to recognize it. And of course, you will first of all recognize that it doesn't look like a kidney. It is usually homogeneous. The cortex is far more large and relatively hypoechoic. The medulla is almost not seen in most fetuses, although it might appear as an echogenic stripe. But the moment you see a lying down fetus, then you start looking for an ectopic kidney. And if you don't see a kidney, then you start looking for the actual fetal adrenal to be lying down, and vice versa. So that's the kind of shuffling you have to do, one giving you a clue for the other. But typically speaking, the lying down adrenal is an excellent marker for either a missing kidney or an ectopic kidney. When we look at a checklist, and I promise you this is not going to be an atlas, this is only going to be highlighting what we do currently. There is a checklist for the entire urinary system, the entire kakut as well, to be diagnosed. Presence or absence of one or both kidneys, the location of these kidneys, shape and contour, they should be reniform, the echo pattern, and you should be able to recognize the kidneys quite differently in terms of echogenicity compared to the liver and the adjacent bowel. You should exclude the presence of cysts, and if there are cysts, then you measure them and you try to study them further, as we will discuss. You look at the renal calyces, the pelvis and the ureter. You should not be able to see any calyceal dilatation whatsoever, and any calyceal dilatation should be looked at very, very carefully. The renal pelvis has some norms, and we will discuss those. And if you see the ureter, you should be able to trace it entirely and see what's going on, and whether it's only a part of it that is dilated, how much is the dilatation, what is the measurement of this dilatation, and the extent in longitudinal extent. The bladder should be seen in a full and empty phase. Excuse me, that's Delhi's pollution, I promise you. That's not corona. And associated anomalies, extremely important, like we discussed in the beginning. Half of these abnormalities are actually part of aneuploidies or a part of syndromes. Amniotic fluid, because we know that the kidneys are the major contributor to amniotic fluid beyond the first few weeks of pregnancy, and that if you find less amniotic fluid, one of the major things that you need to look for is the kidney. And the moment you find a kidney abnormality, we used to think, of course, that amniotic fluid is an indicator of kidney function, but that may not be so. You could have an acute renal shutdown and plenty of amniotic fluid. You could also have poorly functioning kidneys with poor specific gravity urine and a normal amount of amniotic fluid. So we have realized over the years that amniotic fluid is not a true indicator of kidney function. We will discuss what the new indicators are. Field growth and Doppler are important because we know that the actual amount of kidney function can be regulated by the changes in the renal artery. And one of the things that happens in fetal adaptation to a growth insult is the fact that it switches off supply to the non-essential organ, and the kidney, technically speaking, is a non-essential organ for the fetus. We actually have these nice, wonderful nomograms on the internet that you could get through. There are several of them. They're all almost identical. That tell you about fetal length with gestational age. But the one thing that you must remember, of course, is that the length does increase with gestational age. And it's at about the time of the anomaly scan, you would find kidneys that are almost equal to the number of weeks of gestation, somewhere with about 2 centimeters or so, 20 millimeters. By the time you reach your growth scan at 30 millimeters, you would find most kidneys between 30 and 35 millimeters. And at term, which is about 40 weeks or so, you will find kidneys that are about 40 to 45 millimeters long. Remember that just giving one measurement does not make logical sense. Just giving 2 measurements does not make logical sense. Either you do all 3 because you make a routine out of it, but you don't have to, that's not protocol. But the one measurement that you might want to give in case you find a dilatation is the AP diameter of the renal pelvis, and that's the one that truly needs to be given. The measurements, like I mentioned, very important to realize, should be in an axial scan of the kidney, and if you can't see both of them in the same, then you do a different section for the other kidney. So don't try and get both of them at the same time. It may not always be possible. They might be much lower and upper relative to each other. Get a good axial section and mark off the pelvis, the walls with the plus marker, and the spine should either be right above, which is the best way to go, or the other one, which is a non-compromised situation, is a 6 o'clock, but definitely not the 3 or the 9, because there the spine will then put the other kidney away and you won't be able to see it. The total kidney size, like I mentioned, can be mentioned in case there has been a relevant history. Do remember that there is an extremely important embryological timetable for the kidney. And one is that urinary volume actually increases with fetal age, and the echogenicity also changes with age. We have echogenic kidneys at the 11 to 14 weeks window. We have kidneys that look like kidneys by 24 weeks. And in between, you might just have a homogeneous echogenicity, which is relatively more than that of the surrounding or the adjacent liver. Again, like I said before, that kidneys may not be apparent all the way up to the 12-week scan. And even at the 12-week scan, you may not see 10 to 20% of the kidneys. Also, importantly, because urine production is less in the first half of pregnancy and may not be abundant until about 24 weeks, a significant number of renal abnormalities will not be picked up during our second trimester or mid-trimester anomaly scan. That means you've given a beautiful report of normal kidneys, no pelviectasis, no cheliectasis, and when they come back for a growth scan, you will find a dilated renal pelvis or a dilated ureter or both, or a dilated urinary bladder, because the manifestation of an obstructive disease will totally depend on the amount of urine formation. It works the other way as well. So if you have a polyfunctioning kidney, you might find an obstructed system at 28 weeks, and when the fetus comes back and the kidneys have failed, you may no longer pick up dilatation. And that is something you have to be very careful about. That means you have to set your eyes with each machine that you're using and ensure that, truly speaking, you get used to what a normal kidney looks like. Otherwise, you never pick up this form of a chronic diseased kidney, which is almost normal in echogenicity, and there is no dilatation. Also, it means that you will not criticize your colleague's report that, oh, I don't know how they see obstruction, they seem to over-report. That is a wrong remark. What we need to do is to realize that things change depending on kidney function, that things change with gestation age, and what was there yesterday may not be there today. What was not there yesterday may be there today, and what is today may not be there tomorrow. You have to use the logic of functioning versus non-functioning kidneys, less functioning versus functioning kidneys, and therefore the amount of obstruction to be associated or seen at that time of the period of gestation. Remember that technology is of great use, like in any other part of fetal ultrasound. Once upon a time, life was simple and we used one single transducer like this one, but we've come a long way. We do realize, and this was the first of the useful transducers, that with the fetus with the spine anterior, if we use a linear transducer of about 9 megahertz, we were seeing excellent delineation of fetal kidney anatomy. Truly working very well. Then, of course, we came up with 3D transducers, giving us a little more orientation. We don't use those, but I do use my matrix transducer generation 2 to demonstrate a kidney in both planes, which is called the biplanar view. So I use color and a view in 2 axes, and I'll show you an example where the transducer can show you one plane, which is your primary plane, and a perpendicular plane, which is your biplane. And it can be done in grayscale, it can be done in color, very, very useful. Remember that the newer transducers, which are single crystal firing transducers, the C2-9 for instance, often change echogenicity, and you really have to be familiar. Also that transvaginal transducer is absolutely completely non-dispensable when you're looking at any anomaly, because it helps you to look at your anomalies better depending on fetal position, and it helps you to sort out associated anomalies, especially of the fetal brain and the fetal heart in the younger fetus and the rest of the anatomy in the younger fetus. But even in the older fetus, if the head is down deep into the pelvis, it will help you to exclude associated cranial abnormalities. It's also important to realize that primarily color and power Doppler can be used to demonstrate abnormal vessels, such as in a tumor, but also the absence of normal vessels. For instance, if you're strongly suspecting that there is no kidney on this side, then you switch on Doppler or power Doppler, you realize there's only one kidney, one renal vessel here, the second one is missing. And here, of course, where we couldn't see any kidneys, and you can notice the paucity of Leica here, there was actually bilateral renal agenesis, also that there were no strange vessels arising from the iliac or the lower part of the aorta, indicating thereby that we're not even looking at a presence of kidneys anywhere, even in an ectopic location. Remember also that color is useful for demonstrating what goes on in an ectopic kidney, because you might find a nice vessel coming off. This is what I was referring to, the biplane. This is done with the matrix transducer, where here, for instance, I wasn't sure what this blob was. It seemed to have some strange vessels. But the moment we put it into 2 planes, we realized that, oh, this is all something that is arising from a midline vessel. And then we realized that it's kidneys that are too close to the center, and therefore it must be a horseshoe kidney. We reviewed this fetus when it was a little older, at about 22 weeks, and we confirmed the presence of a horseshoe kidney, of course, clinically of no significance. When it comes to looking at cystic spaces that you're not sure of, like in this particular one, cystic spaces in the renal fossa, cystic spaces below the renal fossa, cystic space in the bladder, and within the bladder another cystic space, it might become a little difficult to sort out. The best thing in that situation is to run a 3D acquisition in one of those long coronal planes in the posterior part of the fetus, and everything stands out instantly because we have inherent contrastiness without using radiological contrast in the fetus. And this is how it works. You can see that there's a double collecting system on either side, as you see in the sepia images below, that the ureters are dilated on both sides, and that within the urinary bladder you see another structure, which obviously would then be a ureterocele. Obviously that ureterocele prolapses and blocks the urethra, and therefore you have a backup of urine in the entire system. So very, very useful. Some of the newer software, such as Sono AVC General, also extremely useful. You just take a clean sweep. Again, you suspect that, of course, these must be bad kidneys. There's a shaggy cortex which is thinned out, and 2 spaces here at the back of the fetus, and that there's a bladder almost coming up. And then you try and do it, and you say, ah, yes, of course. There's an inversion and then a color assignment that is a part of the software. You have to just press a single button, and you realize that they're very, very short ureters, that there's bilateral hydronephrosis, and a hugely enlarged urinary bladder, about 10 times as large as each of the kidneys. Let's come to the first of our differential diagnoses, and that is echogenic kidneys. Remember that they might be normal sized echogenic kidneys, as you see here, or they might be large echogenic kidneys, as you see here, And they may be unilateral or bilateral. The vast majority of them are bilateral. Remember that while you're doing this, you start looking for associated abnormalities, such as here, where we realize that the heart is truly pushed to the opposite side, or in this other case, where we realize that there is a posterior fossa anomaly. Remember that echogenicity again would depend on your equipment. Low-end equipment would miss it completely. High-end equipment would make everything more echogenic. You have to be used to the equipment that you use. We don't stop thinking in terms of just a CMV infection or an infantile polycystic kidney disease. Remember, it could be a normal variant, it could be trisomy 13, it could be a Bardet-Biedl, Zellweger, or Beckwith-Wiedemann syndrome, or a trisomy 18 as well. And therefore, then you start thinking on those lines, both in terms of imaging and in terms of genetics, so that you can give an appropriate perspective, because that would be important to give. For instance, if you were to finally diagnose infantile polycystic kidney disease, we know this is autosomal recessive, and you know that it has other associations and other systems, but that the recurrence rate is very high, and the patient needs to be counseled that 1 in 4 babies will be affected. Remember that in this situation, to differentiate the autosomal recessive polycystic kidney disease from all the other conditions, the kidneys are usually enlarged and greater than the 95th centile, and therefore measurements might be very, very useful. Also, very often once you cross over by the 22 weeks, you will realize that there's an empty urinary bladder and oligoamnios. But do remember that you might miss this diagnosis completely, because the kidneys between 18 and 20 weeks might look completely normal. And therefore, if there is a background, then just call the patient right back for a review at 22 weeks of gestation. Remember also that when we are looking at the kidney, don't look at frozen images. Always look at it yourself and try and see how much of that echogenicity is in the periphery and how much is in the center, because sometimes the clue to disease lies in that. Twins, for instance, both with large kidneys, and notice how there is far more cystic space in the center of both these kidneys, here and here. And that would be the classic appearance of the autosomal recessive polycystic kidney disease. So it's not always uniformly echogenic. You will find a lot more spaces, cystic spaces, towards the center. We know very well that it is a cystic kidney and yet echogenic, because the cyst is too small, and all we are seeing, the walls abutting each other, and therefore they don't appear as true cysts. You also need to differentiate other types of cysts, and that is the next category. And the most common cause there is the multicystic dysplastic kidney, where you find cysts of different sizes occupying either part of a kidney or the whole of one kidney or both kidneys or even a supernumerary kidney. And this appearance is quite different from this appearance, where you have an irregular kidney with tiny small cysts in the echogenic cortex. This is the classical kidney that we call the obstructive dysplastic kidney, best seen in this 4th image here and this 3rd image over here. That there are large cystic spaces outside on the periphery, and that is what looks abnormal. If you do a casual glance, you will never pick this up. But if you're aware of the condition, you will always pick this up, and that becomes useful because it has a tremendous bearing on the outcome. Remember that we had a wonderful old classification of the multicystic kidney by Simon Marr, which he prepared for ISWOG, where he mentioned that you must look at the other kidney always very carefully, because therein lies the prognosis. You could have a very ugly multicystic kidney on one side, and of course on the other side a perfectly normal kidney, and have a completely normal quality of life. Or you could have a bilateral multicystic kidney where the quality of life would be 0, and therefore this becomes a lethal abnormality. He also went on to describe the fact that you could have a multicystic change in a small kidney which is atrophic, and you could have some part of that kidney is quite all right. He also went on to describe that if you have a duplex system, one of them could be multicystic and the other one could be quite all right. And of course that you could have multicystic changes even in a mal-ascended kidney. He also went on to tell us then that ultimately this kidney can atrophy even in the antenatal phase. So multicystic kidney seen at 18 to 20 weeks might be seen as an absent kidney, truly speaking, later on in pregnancy at 30 weeks or at 36 weeks or at term. Remember that you could even have a multicystic component in a horseshoe kidney as shown in the bottom-most left picture. This chart again is available as a free download on the ISWOG website or on the internet, anywhere as a chart by Simon Mao and his colleagues. The other differential diagnosis in terms of focal lesions would be renal tumors. Most of these are mesoblastic nephromas, benign solid masses, but how do you tell them they are benign? Very difficult to tell, so only time can tell that. The Wilms tumor is often malignant. These are large masses replacing the whole kidney compared to the mesoblastic nephroma, where you often see some part of normal kidney. These type of masses might be part of syndromes. Polyamnios is not unusual. The differential diagnosis invariably includes adrenal masses, and like all masses, we normally tend to pick them up after pregnancy is more than halfway through, and certainly more after 26 weeks. But there could also be extra pulmonary sequestrations, extra lobar sequestrations sitting outside the thorax itself. We move on to other parts of what I want to talk about Kakut. As I promised, this is not going to be an atlas of what we see. This is going to be on relatively what are newer concepts and opening your minds to certain morphologies that I wanted you to recognize. We're through with those morphologies and we will now move on to urinary tract dilatation. And we know that this is seen very frequently. 1 to 2% of all fetuses will show some sort of a dilatation. Very often it will have no consequence in the long run. But one of the problems is that we've never been talking on the same page, and let's see what these pages were all about. Long ago, Peter Dublé again gave us this. And he said, you decide whether you're before 20 weeks or after 20 weeks. The cutoff for normal is 4 millimeters and less at less than 20 weeks and less than 5 millimeters after 20 weeks. He labeled 4 to 6 as borderline before 20 and 5 to 9 after 20, and more than 7 as pelviectasis at 16 to 20 weeks, and more than 10 as pelviectasis after 20 weeks. And this was based on the fact that if you use the 10 millimeter cutoff, which we've used for many years, we do realize that most of them would require no treatment, no antibiotics for UTI, no antibiotics for UTI and surgery, etc., and no surgery at all if they were less than 10 millimeters. But this was older data. We do realize now that things are a little different, and that there are some that will progress and progress significantly, and that odd group can be prevented from a destroyed kidney by following them up in the postnatal period for making sure. And therefore we moved on to a completely new classification, which is published now in several places. This is no longer that new. This came out first in 2014 and has been in extensive use for the past 5 years. And this was a multidisciplinary consensus on the classification of prenatal and postnatal urinary tract dilatation and what we should be using. The first time it was published was in the Journal of Pediatric Urology, but now it's available in several other journals. And it replaced our older one. In the United States of America, they still use the Society of Fetal Urology classification, which is normal kidney or a slit-like pelvis or a wider pelvis with minimal fullness of the calyces, more fullness of the renal pelvis and a globularity, fullness of the calyces and normal cortex, and fullness of the calyces with a thinned out cortex. Americans still use this. So if you want to communicate with an American surgeon and a patient has overseas contacts, then maybe you should mention the SFU classification in terms of grading. But what we moved on to is this, which is a nice imaging protocol that comes in through that, and then all the measurements. And we will discuss measurements shortly. But essentially what we do is that we focus on and measure when dilated the AP diameter of the renal pelvis. We look to see whether there is dilatation of the central or the peripheral calyces. We look at parenchymal thickness. We look at the appearance of the parenchyma. This is all subjective. We look for dilatation of the ureter or overdistension of the bladder. Remember that the dilatation of the ureter is always abnormal but may be transient, so you wait for it to go away. Remember that when you look at the bladder, you will look for a ureterous seal. You will also look for a dilated posterior urethra. and you will evaluate wall thickness. The cutoff is not 1 millimeter, the cutoff is less than 3 millimeters. So 1 and 2 and 2.9 are normal. Genitalia would depend on the PCP and DT environment. Genitalia can be looked at in all these conditions because it forms part of a diagnosis. However, unfortunately, scientists are not always part of the PCP and DT team, and it may be misunderstood. So I would request you to use caution and to be a little savvy on your own PCP and DT environment and decide accordingly. There may or may not be a urinoma. You must of course always do a complete fetal survey and look for ascites, because you could find a urinary ascites, a very dilated system today, and 2 weeks later no dilatation and just ascites. You start wondering, is this CMV, cytomegalovirus infection, or not? It isn't. It's just a system that has given way and formed either a urinoma or formed ascites. So what do we use now in terms of the classification? We divide the fetus into whether it's less than 27 weeks old or it's 28 weeks or more. Normal, less than 4 millimeters up to 27 weeks, and less than 7 millimeters after 28 weeks. And then of course the rest as I explained. And in the postnatal period we use 10 millimeters as a cutoff. Remember that we used to use an older bit of additional criterion, which is renal pelvis AP diameter divided by renal AP diameter, and if that was more than 50%, we don't use that anymore. We use absolute values. Then you open your mind to the level of obstruction. We know it could be transient or physiological, or it could be a ureteropelvic junction or a VU reflux, a ureterovesical junction obstruction, posterior urethral valves, some of the unusual ones which are the ones I've listed here and we've spoken about, but usually the vast majority are transient and they will go away if you watch the fetus for long enough. Remember, depending on the level of obstruction, you might find only cheliectasis, pelviectasis, ureteric dilatation, and overdistended urinary bladder, or a visualization of the urethra, and therefore you have to go through all of that. Again, the best way to confirm what is going on is to watch things over a period of time and keep looking for those, and make sure that when you see a dilated system, you look at the parenchyma just like I said, you confirm that it's reniform, you wait and look for the kidneys and see whether they fill up even more. Then you try and see and wait for the ureters to fill. Do they fill up? Do they not? Is there anything washing up from the bladder? There I see a transient filling of the ureter. I will wait many minutes before I confirm that. And once I see what all is filled up, I move on to try and make sure that what I'm looking at is truly a urinary bladder, and I will confirm that by putting color on the side and making sure that yes indeed this is a dilated posterior urethra, that this is the bladder, and I see all the I see both the urinary both the umbilical arteries on the side. Remember that there is this huge amount of importance given to urinary dilatation from a complete workup point of view, not only from what we see on the ultrasound, but the associated syndromic conditions, also the associated genetic conditions. When we find an isolated pelviectasis, then basically the risk of chromosomal abnormalities is low, and the only one we really see is a trisomy 21. And it's not really a major factor anymore when we see it at the time of the genetic sonogram that we do at 18 to 20 weeks. We find that it truly has very little value. The non-chromosomal ones are far more common, and therefore you will start looking at the entire fetus. On the other hand, when you look at hydroureteronephrosis, you realize that in that situation, the chromosomal abnormalities are even fewer, and usually this is not syndromic, it's obstructive. If you find a dilated urinary bladder, the risk of chromosomal abnormalities is relatively high, and again the chances of being a syndromic finding is relatively high. The genetics of this whole condition has moved a lot, and we will now spend a few minutes on this, and that is that when you find a dilated system or an abnormal system, you start thinking what we call the ciliopathies. The more common ones include Meckel-Gruber, Joubert syndrome, and Bardet-Biedl, but you also have the other syndromes, which are the Senior-Loken, nephronophthisis, and Leber's congenital omorosis. Remember that all of these would find some degree of disease outside the kidney, And therefore, you will have to look at all the way down from things like cerebellar hypoplasia, encephaloceles of the Meckel-Gruber, cysts in the liver associated with any of these, polydactyly associated with a large number of them, cardiac abnormalities, skeletal abnormalities, and cleft palate, which again we find more commonly in the Meckel-Gruber. So all of these need to be looked for, and then you start thinking in terms of a ciliopathy. The ciliopathies, when we look at the various genes, are again multigenic, polygenic. There's a large number of genes associated with them, and notice how many of these genes can be present as abnormal mutants in a large number of these conditions. So we realize now that these ciliopathies are actually an overlapping condition. So if I find a polydactyly, it could be part of Meckel-Gruber, it could be part of orofacial digital syndrome, it could be part of Joubert's, and it could be a part of nephronophthisis. If I find that there is an association with cystic kidneys and polydactyly, then I could again be part of polycystic kidneys or part of Meckel-Gruber or part of Joubert, and I must be aware of this. That even when I analyze, I have to be truly careful. So when I look at genetics, we realize two things. One, that there have been a lot of advances. B, that we still don't diagnose all of them. About 2/3 of them are identified, the remaining 1/3 still remain a dilemma. And typically, we find that if I were to use a targeted gene panel for that bunch of genes that we just mentioned, I would end up identifying 62% of them. And if I do a whole exome sequencing, I would identify about 44%. Therefore, we're still far from the total diagnosis, and we must explain this to our patient that, look, we're using expensive tests for you. I would like to first do a targeted gene panel because it's a little less expensive, or I'd like to do a whole exome, or in case there are too many genes and they require too much of a Sanger sequencing, then I'd rather do a whole exome first. So you have to be aware. So the most important thing that we have to do as an obstetrician, or as someone in fetal medicine, or as a radiologist, is to make sure that we involve a geneticist, because this is something that you and me are not capable of handling by ourselves. We truly must understand that. Also, that in this entire thing, whether we're looking at primary ciliopathies or motile ciliopathies, we have to keep our mind open that yes, we will store up some DNA. And it's not that it's rare. When we look at this wonderful project called the 100,000 Genome Project, which is now in progress, we find that the ciliopathies constitute about 1% of these, and therefore, obviously there is much more. These are rare, no doubt. But the individual patient will come to you because you are reaching that level of specialization, and then we should be absolutely able to understand what is going on. Also, that we've understood some of these proteins more than others. And therefore, we now have an answer from a genetic point of view, at least in mice. For instance, eupetillin, it relieved ciliogenesis defects from the inactivation of the CEP290 gene that had happened, and it worked in mice, and it might be the answer in humans in the near future. So this business of a genetic testing for any fetus that we find abnormal has to go beyond a trisomy 21 and a microarray to perhaps targeted genes or a whole exome sequencing. The second last part we're going to talk about is the fact that we now have a different way of looking at renal function. We thought we were very smart, and we used to say echogenic kidneys, bad kidneys. Good looking kidneys, fine kidneys. That was completely wrong. Oligoamnios, mistaken. Flow, not an indicator. Fetal urine biochemistry obtained by puncturing the bladder. We don't know how long this urine has been lying in the bladder. If I puncture it the first time, I might get old urine. If the kidneys are functioning and the bladder fills up again and I puncture it the second time, I might get fresh urine. And we used to add on these fancy names which are usually not available in most parts of the world, which is what are the electrolytes like, which are urinary proteins like, and can we quantify those in that small quantity of urine. The beta microglobulin, which is greater than 6, or the unpronounceable tubular enzyme that is written over here. These never worked. people keep bringing these up, they keep resurfacing, they don't work. What has worked is this absolutely brilliant piece of literature that we've learned from Cartier-Bellado's group last year and was published in the White Journal and widely publicized at various meetings because their group spoke so well and gave us so much information. And that is that to assess renal function in the long term, you go back to the original scan if you have one. So if you've had a fetus that presents with a urinary abnormality later, look back to see whether it had an increased nuchal translucency or not. And if it did, that's a bad prognosis. If the longitudinal diameter of the urinary bladder was more than 12 and not 7 or 15 as the old landmarks, bad prognosis. And the presence of umbilical cord cysts at the time of any of the previous scans are markers of a poor prognosis. Interestingly, all of them surrogate markers, indirect markers, and yet remarkably predictable than the actual appearances on imaging in the scan where you diagnose obstruction. And this was important because we do realize that over the years the Pluto trial failed, which was trying to figure out who will benefit from a catheterization, who will benefit from a permanent catheterization or just a puncture. And we used to pretend that by emptying out urinary bladders we were improving kidney function. Transient, and the fetus that were going to survive would have survived anyway, and the fetus who were going to go into chronic renal failure would go into chronic renal failure anyway. Therefore the Pluto trial was closed. In fact, there were not enough volunteers. Then we realized that yes, the only treatment that works is an in utero endoscopic valve ablation where you do a temporary relief, and that might work. Nothing else works. The rest of the fetuses will follow their natural destiny of death or survival or chronic renal failure. And that is why now the emphasis is on trying to figure out as early as possible and find a surgeon who as early as possible would handle this situation, or train yourself as a fetal surgeon. The last thing I'm going to talk about is a little more detail on what the multidisciplinary group have done, and that is to classify AP diameter of the renal pelvis from 16 to 27 weeks versus 28 weeks, 4 to less than 7 without any chalicial dilatation is estimated as urinary tract dilatation A1, which is low risk, and after 28 weeks we use a 7 to less than 10. If it is more than 7 up to 28 weeks and more than 10 after 28 weeks, then you start looking for any of these, which is peripheral chalicial dilatation, parenchymal thickness, parenchymal appearance, dilated ureters, over-distended bladder or trabeculated bladder, unexplained oligoamnios. That puts it into urinary tract dilatation A2, A3 and increased risk. And that is important because on the basis of this, you will decide what you have to do during the pregnancy and after the pregnancy. So if you had a urinary tract dilatation A1, which is low risk, one additional ultrasound beyond 32 weeks, 2 scans at least 48 hours to a month after birth, at least 48 hours because we know that the kidneys don't function much for the first 48 hours. You might miss obstruction completely. So wait for 48 hours and preferably up to 1 week to a month, and then of course one about 6 months down the line. Of course, if we find just a little more than 4 millimeter renal pelvis, you will look back and see what it scores on the Agatha Clio score and what is the new risk when you multiply the a priori risk compared to the fact that this is a finding. If you have a urinary tract dilatation of the A2 or 3 category, you usually do a scan initially in about 4 to 6 weeks, and then make sure that you have a special consultation soon after birth to handle this matter, because things could go differently. So the moment you find this business of more than 7 up to about 28 weeks category and that 10 millimeter later on, you have to start being very careful. Because based on this also we have a postnatal presentation which, because we're limited for time, I won't go through, but essentially that is the realm of what the pediatric surgeon is going to approach during his evaluation. Also, the pediatric surgeons still have it to their discretion to decide whether we need avoiding cystourethrogram, whether we need prophylactic antibiotics, or whether we need a functional nuclear medicine scan, and therefore we won't go into that. What I'd like to do is to point out once again that we always, for trisomy 21, I use the Gathocleos chart from 2013, where we use any a priori risk available. If I find this at the time of my genetic sonogram, I find out whether I have a risk from my first trimester biochemistry, a risk from my first trimester ultrasound, a risk from a quadruple test, and so on, and then I look at this. Of course, if I've had an NIPT done, then I don't look at these at all, just like we do for any of the other things when I do an NIPT. So I'd like to end this evening by showing you the famous list again, saying that, look, we have a lot of new things. I've touched on the relatively new topics. I've reinforced some of the old beliefs, certainly not an atlas, otherwise you'd have got bored. And I imagine you've all listened also on the side to what our Prime Minister Modi has said tonight about what life is going to be with Corona. We try and follow those and be safe. Meanwhile, for our everyday life, we will look at the presence or absence of one or both kidneys, look at the location, shape and contour, look at the echo pattern, look for the presence of cysts, look for calyces and whether they are dilated or not, look at pelvic dilatation, look at ureteric dilatation. Remember to see the urinary bladder both full and empty. Look for associated anomalies, look for associated anomalies, look for associated anomalies. Think genetics involve a geneticist. Look at amniotic fluid as an index of possible kidney abnormality, and look at fetal growth to make sure what is going on. And thank you very much for your attention. We already have the first of our questions coming in, and it says, sir, just like by turning off harmonics can be useful to diagnose echogenic bowel, as you said, to differentiate the echogenic kidney. Yes, absolutely. That you must always check the echogenic kidney by turning off harmonics, particularly when you're younger. Later on, of course, you learn to recognize it because you get so used to the image. So you get used to what we call pattern recognition or intensity recognition. And perhaps in the future, we might actually use artificial intelligence to identify how echogenic is this kidney. So I will take an image and I will send it to an agency that recognizes renal echogenicity, and I have an answer. It tells me echogenic versus not echogenic kidneys. Or it tells me, look, can you please send me another image after switching off harmonics, and I'll tell you whether this is echogenic or not echogenic and how abnormally echogenic is it. And that is the future artificial intelligence. Do we need to exclude genetic abnormalities in case of any kakut? Yes. But that does not mean an amniocentesis. If I have an isolated pelviectasis of 4.5 millimeters, like I said, I'm going to look at my age risk, my added on nuchal translucency and additional parameter risk, my added on biochemical risk, my added on quadruple marker risk, my added on perhaps pentamarker risk in case I did that in the first trimester, my genetic sonogram risk because of this one factor and the absence of the others, and then I decide what is my new risk and give the patient the options. When I look at kidneys that have a strange echogenicity, I will again definitely make sure that this is well looked after. If I look at a simple classical multicystic dysplastic kidney, I might ignore it. If I find what I'm mistaking for as a bilateral multicystic dysplastic kidney and I want to know what future pregnancies are like, I will definitely like to do a genetic evaluation. Echogenic kidneys, always a genetic evaluation to exclude the trisomies, to exclude a CMV evaluation at the same time, and then of course a detailed clinical history, a pedigree, a complete genetic evaluation. Start off with what I think is appropriate, a gene panel or a whole exome, And then, of course, depending on what my whole exome says or what my clinical exome says, I would start and say, okay, do I need to identify those genes? And then I would confirm what I find, for instance, on a clinical exome with the Sanger sequencing. So all of that needs to be done. And each one of these you have to work out very specifically. Some of this information is so new that you can really get stuck. And if you're in the periphery, then I would suggest you move on to reading something called Frontiers in Genetics. Frontiers in Prenatal Genetics, which is a great site, and it tells you a lot of these new things. But the best thing would be just to phone a genetics friend and say, look, I find this appearance, you study it, I study it, I'm going to keep the patient waiting, and let's see what best we can do for it. In that situation, invasive testing is better. Some of us say, look, I can do genetic testing on a situation where I will terminate the pregnancy and send you the placenta. DNA evaluation from a placenta is not that hot compared to DNA evaluation from amniotic fluid. And every geneticist will agree with you on this. Yes, we will use it when push comes to shove. We'll certainly never get a proper karyotype, for instance, on necrotic products of conception. And you might not even get a QFPCR because there would always be contamination. You might pick up a fish. But let's face it, we're not looking too much beyond 21, 13, 18, which you would have picked up anyway. So therefore, what we will always do is an antenatal investigation, even if we're going to terminate that pregnancy. There is a question on what is the importance of a persistent left umbilical vein. That means that I will find a 4-vessel cord, 2 umbilical arteries and technically 2 umbilical veins, and I might find these at the placental end of the cord, I might find these at the umbilical end of the cord, and I might find these even in the upper abdomen of the fetus. No consistent abnormality and no fixed abnormality, and if I don't find associated abnormalities, I do not get too worried about 2 veins. Whenever I find any venous abnormality, even of this persistent left umbilical vein, I will look for other umbilical vein abnormalities in the fetus, such as umbilical vein abnormalities at the level of the portal venous system, such as ductus venosus agenesis, such as abnormalities of the vena cava, and such as some of the abnormalities of the anomalies of pulmonary venous drainage. So that group goes hand in hand, but nothing to do specifically with urinary tract abnormalities. We really have a charming number of questions, and I'll go through these. And there's a nice question here. What are the causes of persistent unilateral echogenic contracted kidney with loss of corticomedullary differentiation with small subcapsular cysts? Other kidneys absolutely normal, no associated abnormalities. I showed you an example of bilateral kidneys that were like this. Those were classically obstructive dysplastic kidneys, bilateral. You could have normal kidney on one side, obstructive dysplastic kidney on the other side, reasonably good prognosis. A little guarded because sometimes you could have reflux killing the only good kidney. So you will explain that to the patient, but reassure them by and large and tell them that, look, come back to me at 28 and 32 weeks and we'll reassure you that everything will be fine. And essentially a postnatal scan after 48 hours and one at 6 months and a referral to a pediatric urologist at an early stage, even in the antenatal period, to reassure them that, look, that is an obstructive dysplastic kidney, that is obstructive dysplasia, the other kidney is normal, there's a solid chance that this kidney will always be normal, don't panic. What is the prognosis of unilateral obstructive multicystic kidneys? Usually very good. Partial or complete unilateral multicystic kidneys and nothing on the other side, we are completely comfortable. But do look at the other side very, very carefully. How do you diagnose bladder exstrophy? Very, very important. Bladder exstrophy essentially means that the bladder never fills. If it does fill partially, it's very flattened and does not have a bladder appearance. The bladder exstrophy also does not have a normal extent of the veins, and we have some nice signs that we use for the abdomen, such as the K sign, and we can use that. And that seems to work out best. But it always remains a differential diagnosis, and very often you're not able to demonstrate this, but the clue lies in being sensitive to the fact that you watch this fetus from morning to afternoon, afternoon to night, and night to next morning, and I didn't get a full urinary bladder, I start thinking of a bladder exstrophy. The rest of the stuff you will do anyway. You will look at ureters, you will look for kidneys, you look for associated abnormalities, you look at the portal vein, you look at the umbilical cord, you look at the angle that the umbilical vein makes with the rest of the system, the key sign like I said, you will look at the urethra, you will look at the genitalia and so on. But essentially, if you are not sensitive to a bladder that doesn't fill, you're going to miss this diagnosis. It's not a crime to miss this diagnosis. What I usually use is, if I don't see a bladder filling, I always look at the genitalia and make sure that they are not ambiguous, because that's the most common association, that you will often find a very small phallus. Okay, if you have NIPT done, do you have important second trimester ultrasound markers? Sensible question, we've answered that already. If I have an NIPT done, I do not need to look at my ultrasound markers. The question is NIPT one test, or are they types of NIPT which have become cheaper and less accurate, less sensitive? Because as a proud Indian, I've asked the NIPT people, bring the test cost down, bring the test cost down, bring the test cost down. Then, my dear, we're not going to have the kind of laboratory evaluation that we usually look for. But a nice, decent NIPT at a reasonable cost for the moment, I mean, they will become cheaper in the future. That's how we push them. But let's face it, a good NIPT, you do not need to do a genetic sonogram after an NIPT. How do I differentiate between autosomal recessive and autosomal dominant polycystic kidney disease? A, the autosomal dominant may not show up. B, at the time of the 20-week scan, the autosomal recessive may not show. The autosomal recessive invariably consists of echogenic enlarged kidneys when we see it. The autosomal dominant consists of random cystic spaces, variably sized, usually occasional, maybe unilateral, maybe bilateral, therefore not difficult at all. If we have an isolated horseshoe kidney in the fetus, what to counsel the patient? We tell them you have an isolated horseshoe kidney, usually of no consequence. We will review this in the few months after the baby is born, and it is extremely unlikely that this will ever give us trouble. Okay, sir, please enlighten us on normal variation, echogenic kidneys seen in the mid-trimester. Normal variation is a diagnosis of exclusion, that you've excluded cytomegalovirus infection, you've excluded trisomy 13 and 18, you have excluded a background of polycystic kidney disease, you have looked very carefully and tried to make sure that you've excluded the ciliopathies, you don't have polydactyly, you don't have a meningocele, a meningoencephalocele, you don't have a little occipital meningocele and so on. You've excluded posterior cranial fossa disorders, you've excluded some of the cardiac situs disorders and so on, and then you say, okay, likely normal variant, extremely likely normal variant. Invariably, the normal variants will become less and less hyperechogenic with the passage of time. So therefore we say, okay, this is fine. But you can't really swear, but usually if you find normal size, normal shape, not very echogenic, and certainly no tubular spaces in the center of the kidney, normal sized kidneys, and you excluded everything else, you can be quite sure that this is very likely to be normal variant. If we have, okay, we've finished this set of questions. Wow, we have a whole lot of more questions. Let's answer these. Isolated bladder dilatation is better or worse compared to complete dilatation of urinary system from a fetal perspective? Interesting. Isolated bladder dilatation, apart from our prognosis where we use a 12 millimeter, 7 to 15 millimeters in the first trimester is what we call the type that we suspect a trisomy 21 strongly, and the one more than 15 we suspect obstruction strongly. If we find that you have excluded the genetic causes, then you of course have a complete dilatation of the urinary system, and again in that it would depend on what is the cause. A not completely obstructive posterior urethral valve will have a good diagnosis. A bilateral VU reflux would have not such a bad diagnosis. In general, what is actually a prognosticator is that the earlier you see urinary obstruction, the worse the prognosis, and the later you see it, the less bad the prognosis. Because the insult has been for a shorter duration of time, and the insult has been much later after a fair number of nephrons has developed. We know that nephrons will keep on developing all the way till 36 weeks. And we know that part of the nephron will mature much later. Therefore, we keep our mind open, but in general, it is more not the, once you've excluded the trisomy 21 bit, the rest of it is not really related to a total obstruction versus non-total obstruction. It depends on the cause of obstruction, and that is what is going to guide you. Then we have to differentiate between multicystic kidneys and polycystic kidney disease. Polycystic kidney usually echogenic small cysts that you can't see as individual cysts. Multicystic is larger cysts, vast majority of them more than 2 to 4 millimeters, and sometimes up to 12 and 14 and 16 and 25 millimeters. And then of course typically the polycystic kidney disease is bilateral diffuse large kidneys. The multicystic is either one whole kidney or part of a kidney, rarely both kidneys, but again very large. Sometimes a little tricky to differentiate between gross hydronephrosis and a multicystic kidney. You rock your transducer, you move it around, and you will often define this. And what I always do is a 3D sweep, and I do a sono AVC. It just lights up my kidneys and I get the answer on 3D. Now, when we have obstructive pathology in kidney, in the case of cystic dysplastic kidney, do we always see obstruction? No, because once the kidney is obstructive, dysplastic and dead, you will not see a dilatation of either the renal pelvis or the calyces or the ureter or the bladder. The insult is over. The kidney stops functioning, doesn't produce urine. That side of the urinary system becomes flaccid. And you will only see a relatively almost okay parenchyma or slightly echogenic and peripherally distributed small cysts. And therefore very often when you diagnose the obstructive dysplastic kidney, you will not see any dilatation of the urinary system. The next question is, if we have unilateral pelvic calyceal and ureteric dilatation with a normal urinary bladder, what can be the cause? The usual cause in that situation is a vesicular-ureteric reflux, a primary megaureter, or a unilateral vesicular-ureteric obstruction, and that is actually associated very often with an ectopic ureter. That means the opening of that ureter is usually not in the right place, and it opens far more inferiorly on the trigone or in the urethra. Also, that most of the time this happens in female fetuses, so again you will do fetal sexing and then take it on from there. Next question, any indication of preterm delivery for bilateral pelviectasis, and at what cutoff? What you mean is iatrogenic preterm delivery to actually look after this. When we do iatrogenic preterm delivery for a kidney condition, we usually find that these fetuses are not mature enough for immediate surgery. So it's self-defeating. So truly speaking, we just leave them to be delivered by their own destiny, and then we see what's going on. Because the premature fetus in no way will be able to take the kind of surgery we're planning. It's too high a risk, will not be accepted by the pediatric urologist or pediatric surgeon, and certainly not by the pediatric anesthesiologist. So that's one. Oh yes. A few more points on Bartter syndrome. To see it prenatally. Again, the question is that when we look at this, Bartter's may be abnormal kidneys, may not be abnormal kidneys. They might come to you with a scenario of a previous abnormality, a scenario with a parental abnormality. And I did show you that slide partially for a little while to see what was going on, and I wasn't able to highlight it, and I think we see it now sitting right there, that we actually try and look for all the possible conditions. That means you try and cover up everything including skeletal dysplasias, and then you try and see what you're picking up. But usually it works the other way around, that you have a family history where you're looking for this and then you find it. Otherwise the changes can be in either the kidney or in any other part of the system, and then you have to work on it backwards. Therefore, invariably I involve with geneticists, because they will always give me more clues than I can give to the whole case by myself. That finishes with this. Yes. In fact, when you find kidney disease with polyamnios, there are two differential diagnoses. First, you see whether it's the left kidney, because sometimes a dilated left kidney can actually be sitting on top of the gastroesophageal junction and interfering with fetal fluid, swallowed fluid, passing into the fetal stomach. And therefore you find polyamnios. And then if you find a bad looking kidney with polyamnios, then again you start thinking in terms of Bartter's, because that's truly what it is, that these kidneys don't really have a structural disorder in that sense. They have a tubular disorder, or a nephronic disorder as we like to call it, and that there is polyuria and therefore a polyamnios. Okay, a few more questions before we close. What does it mean 28 weeks antenatal scan report given mild right hydronephrosis? Well, not enough. We must know what is the AP diameter and the rest of it. This is an incomplete report, obviously. A baby came for routine checkup at 6 weeks. How to follow up? Very simple. We do an ultrasound of the baby for the kidneys, urinary bladder and post-micturition. We measure the thickness of the urinary bladder as routine. We measure the AP diameter of the renal pelvis as routine. You measure the kidneys and you look at it, and depending on your findings, you will then call them back depending on what you find. Like I said before, we have a risk stratification depending on postnatal findings, and therefore you will follow those. It makes life much easier. That yes, you stratify the risk on the basis of this report that I showed you, or whether it is after birth 10 to 15 millimeters, greater than 15 millimeters, and then also whether there was or not a parenchymal abnormality at that time, and depending on that, then you will refer to a surgeon who will then decide on whether a functional scan and a voiding study is required or not. So that is the way you would follow this up. Bilateral renomegaly with increased echoes, we've discussed this extensively. The larger the kidney, the greater the chance of autosomal recessive, and with the rest of the group, we normally find normal sized kidneys. How to assess the renal parenchyma thickness in the kidney? I just love this question. I love this question because even in the adult, we are in the habit of always saying renal parenchymal thickness. You look anywhere, you will not find references to renal cortical thickness or renal parenchymal thickness for fetuses or adults. Nothing that is ever correlated enough. It's always subjective. I think this looks thick, I don't think this looks thick, and I have the experience to say so. Purely subjective. Ruptured fetal bladder causes. The most common cause is a critical obstruction of the outflow, invariably. The second cause is iatrogenic. And then you have some of the rarer causes, which some people feel that when a bladder ruptures, that is how an exstrophy happens. We know that's not truly the situation. We know that the other possibility that it's not truly a rupture of the bladder, that the bladder has gone and emptied out as a urinoma somewhere else, or that a bladder is emptied into the vagina, or that the bladder is emptied into the rectosigmoid. Therefore, you have to be careful on what we call a bladder rupture. And you have some rare case reports of various other causes, such as a lot of necrotizing infections, vascular causes, etc. They're merely case reports. I've never ever seen a single one, truly speaking, except a urethral atresia going in for rupture. How to differentiate cystic lower abdominal lesion from urinary bladder in OEIS complex? I just use the case sign. And a very nice question. Can we diagnose congenital adrenal hyperplasia in the antenatal scan? The fact remains that most abnormal kidneys will be seen as abnormal kidneys, but most abnormal adrenals will not be seen as enlarged adrenals. Yes, if you see a globular adrenal, unilateral, bilateral, you might be able to diagnose it in an appropriate background. Then you will look at the genitals carefully. But if you don't have an appropriate background, then you're not going to be able to diagnose congenital adrenal hyperplasia in that particular background. The role of ultrasound is purely in fetal sexing to decide whether that fetus needs to be supplemented or not to be supplemented because of the hydroxylase deficiency. I know we're running out of time, but if I may be allowed to take just 2 questions. At 30 weeks, kidney sizes are 41 to 43, fetal weight 93rd percentile. How to do counseling of parents? We not only go by the actual value, we also go by the number of how far it is from the median, and someday we might even come up with multiples of median. But the fact remains that if the fetal weight is on the 93rd centile, that's normal. Kidneys at 41 to 43 are relatively bulky, but that's in the normal range. I may not even mention it. I'll just say, okay, come back again at 36 weeks so that we decide whether there is a Beckwith-Wiedemann. I'd look carefully at the tongue to see whether there's a big tongue or not. I'd like to look for some of the other causes. I'd like to look for the mid-arm circumference as a measurement, but I really would not worry too much about it. It's a question of how you convey. See, the question is, if you do convey this to the patient, there's nothing you can do antenatally. And if patient asks me too many questions and they're really going beyond the point in 45 minutes of counseling, then I say, look, you have to learn to trust in a higher spirit or God or whatever you want to call it. We can't give you all the answers all the time. Most of the time this turns out to be alright. Occasionally it may not and might need some attention. Let's follow it up. Let's hope we go on the correct side. At any rate, we'll try and make an early diagnosis and see that we give the baby the best outcome. That's the best way to go about it. Everybody wants to look for guarantees. And we have to convince the Indian patient that there are no guarantees in biology. We have statistics to go by, and this is it. We can't play God. You and me cannot play God. We are not God. We are human beings, and our profession is the medical profession. We must accept that. And we must realize that the day we play God, we're running into the hands of the consumer forum. And that's a very easy access for any patient today. All we need to do is to do 2 things. Lay it straight. Also document. Make them sign it. Video counseling, the way we go in the future. And ensure that you're insured for at least 1 crore rupees. More if possible. Can unilateral hydronephrosis consider a marker of genetic sonogram? It is. It is definitely a marker. It is one of the 8 findings. It has a positive likelihood ratio and a negative likelihood ratio, and we will use that as a calculation. Of course, if you've done an NIPT, we don't need to use it. If you have a calculation of 1 in 10,000 as your a priori risk, you don't need to use it. But it sounds nice on a mathematical report if you say, yes, a priori risk 1 in 8,346, this is present, and therefore now my risk changes to 8,994, or whatever figure it turns out to be. Simple. Any more questions? Before this switches off. Okay. When do you call back a pregnant patient for a follow-up ultrasound if she has pilectasis at 21 weeks? At 21 weeks, I will measure very carefully. And there is nothing really that I can do between 21 weeks and term. So from a NHS point of view, for instance, I don't need to call her back. We just say we will see, and we will see when the baby arrives. We will put her through a fetal medicine consultation if she hasn't had one already, or if you don't have the background, the experience. I would put her through a genetic evaluation completely, and I would like to see what is the cause of the pilectasis, isolated or not isolated. I would like to see the extent of the pilectasis and then decide. And then beyond that, for my 21 weeker, I would assess her personality. Nothing objective, nothing scientific, nothing recommended, not known protocol. They feel very reassured that I'll say, well, let's look at the baby nicely when it grows up. Come back in about 24 weeks. We'll look at the heart more carefully. We'll reassure ourselves that everything is perfect, that you can happily deliver here and you don't have to go anywhere to deliver. And at 24 weeks, I'll tell her, come back at 28 weeks. Let's make sure you're not getting too depressed and you're still eating well. And then at 28 weeks, I'll say, okay, this looks fine. Are you more comfortable at coming back at 36 weeks, or are you more comfortable coming back every month? 9 out of 10 will say, can I come back after 4 weeks? Is it okay? Fine. Scientifically speaking, she really doesn't need a reassessment for a long time, because whatever you're going to do, you're going to do postnatally. And they are to be told, okay, it's your luck, it's your destiny, don't play God. But you can't tell that straight to a person, to their face. We're not trained like that. We're human beings. The patient is a human being. And therefore you have to go step by step, assess every being for what they are. Make sure you counsel not just the patient but the family, not just the family but the relatives, not just the mother-in-law but the whole community, not just the community but the whole village, and if necessary, all their doctors concerned. We do spend a lot of time on WhatsApp, you and me. Let's face it, let's spend some of that time on phone calls. Phone calls are a great way of communication, and it keeps everybody happy. Ring up the patient occasionally, ask your secretary to ring up and say, how are you doing? Is everything okay? You were supposed to come in for a scan, you didn't come. Or when would you like us to schedule this scan? Those are the ways to go about it. Technically speaking, science speaking, NHS protocols, AIUM protocols, RCOG, you don't need to do any of this. Any more questions?
No.
Wonderful. And with that, we come to an end. And God help us from Corona. Take care of yourself. We are at the highest risk for contracting this disease. We do understand that even if we get it, a lot of us will have mild forms of disease because we're not immune compromised. But let us protect ourselves first and also teach our patients protection second. God bless you. Thank you very much.